that you read it.
We're dermatologists, and we've come a long way since that time. The pathogenesis of the condition was understood to a much better extent in 1963, when the enzyme deficiency and the role of substrate accumulation began to be unravelled, and then the genetic basis was revealed with unravelling of the mutations that underlie the condition. And we were fortunate that in 2001 specific treatments were introduced, and since that time about the safety and efficacy of the enzyme replacement preparations. And this slide just talks about some of the things that have been achieved over that period of time. So certainly in terms of the range of clinical manifestations, we've got quite a clear idea of the broad range of clinical manifestations underlying this condition. We've got an increasing recognition of the variants that occur. So we've already heard about the differences between classical Fabry disease and the later onset variants. I think that's something that we'll be hearing more and more about as the knowledge of this condition increases. The variability in females, the fact that females can develop symptoms often as severe as males, but the recognition also that there can be females who are genetically affected but have no symptoms whatsoever. That's something else that we've come very clearly to recognise in the last 2 decades. The importance...
Yes. I preferred Professor Germain's definition.
Yes.
Seemingly asymptomatic.
Seemingly asymptomatic. Right. I think seemingly asymptomatic is an appropriate term. The importance of this multidisciplinary approach, I think that's something that's been very much appreciated in the last few years. I'll talk a little about the importance of supportive therapies, because although we've got enzyme replacement by itself, it's not sufficient. And I've listed there some of the other important things that have been achieved over the last few years. We've heard quite a bit about the multi-system nature of this condition, and we'll be exploring that a little bit further later this morning as well. We will have Sandra Ferriozzi explaining just how frequent renal impairment is in this condition, the nature of renal impairment, the implications it has for patients and treatment. You'll see there that it's certainly a problem in the majority of patients with Fabry disease. Peter's given us a very full overview of how cardiac disease can affect Fabry patients. Cerebrovascular involvement is something I'll be commenting on. It's an increasingly recognised problem: stroke, ischemia, transient ischemic attacks. The slide there also talks about some of the aspects that I know are a major issue for patients. The gastrointestinal symptoms of Fabry disease, griping, abdominal pains, diarrhea, constipation. Many patients tell us about these symptoms. Many patients seem to accept them as part of their everyday life. It's a whole area of Fabry disease that I think is underexplored. It's an area which I think is of increasing importance. I'm certainly hearing and seeing in our own cohort patients who have severe gastrointestinal symptoms, often symptoms of a different nature to those that we've recognised in the past. I think what we're seeing there is patients who are living longer, living through some of the cardiac complications, living through some of the central nervous system complications, and we're seeing parts of the natural history of Fabry disease which perhaps we haven't seen before. So I think gastrointestinal complications is an area that warrants increasing focus in the future. We've heard quite a bit about these disease variants. I want to say a little more about stroke. these are some of the central nervous system challenges. White matter lesions, what do they mean? You'll know that these are changes that we see in the MRI of patients with Fabry disease, and we see these changes frequently. Here's a patient who is on enzyme replacement therapy, and you can see changes which at 4 years, you can see these changes here. They were possibly present earlier. This individual's on enzyme replacement therapy, and it's obviously a source of anxiety to all of us that these features of the condition are progressive. Even though the changes are probably in quite close opposition to parts of the brain that are well perfused, the enzyme therapy doesn't seem to have an impact on the prevalence or the size of white matter lesions. Yes?
I wasn't able to attend, but at the World Symposium, I understand there was a poster. So up until now, research indicates that enzyme replacement therapy may not help with the cerebrovascular symptoms. But I understand there was a poster at the World Symposium that opened the window a little bit to perhaps ERT is of some help.
Yes, I'm aware of that debate, and you raised the very important point that there is work that can be presented and even published as posters and as abstracts, and is then subject to rigorous scrutiny before publication. And it's possible that such scrutiny leads people to really look to see what the evidence is, because you'll be aware that there is a lot of data on the prevalence of these white matter lesions, and there have been studies that have looked at MRI appearances and recorded MRI appearances, but the impact of enzyme therapy on these appearances was not the primary objective of the study.
Right.
So I think you do raise an important point about scientists and clinicians being very rigorous in terms of the publications that they're responsible for. So I'm aware that there's a debate on whether ERT has an impact. And I'm not necessarily saying it doesn't have an impact, but I'm giving an illustration of a patient where it didn't have an impact, and really raising this as a challenge. The whole issue of the central nervous system effects of Fabry disease is very much a challenge for us for the future.
Yeah, I understand the paper wasn't directly relevant to white matter lesions, but just that there may be some benefit to
there may be some benefit
in the brain.
Yeah. And there may be some benefit in terms of alterations in cerebral blood flow. You may know that the studies in fact indicate that patients with Fabry disease at baseline appear to have an increase in cerebral blood flow. So there's a dysregulation of cerebral blood flow, and enzyme replacement therapy has been reported to reduce cerebral blood flow. In other words, to restore a degree of normality to the controlling mechanisms. But quite how that occurs, or why that occurs, is improperly understood. I mean, at one point it's encouraging that there are these documented vascular abnormalities, but you'll see, I mean, that's an area where there's abnormal perfusion. But here's a patient with Fabry disease with really severe changes in the basilar circulation. You'll know that often the parts of the brain where strokes occur in Fabry disease tends to be at the posterior circulation relatively more than the anterior circulation. And patients with Fabry disease have vascular abnormalities. Some of these vascular abnormalities lead to disturbances of blood flow. Some of these vascular abnormalities are due to structural changes in the blood vessels. And Uma, amongst others, has shown us that you can visualize some of these structural changes by close examination of the retina. That also can show these changes. But the precise pathophysiology underlying these structural changes is again something that's not well understood, and it's another challenge for us to try and unravel why that happens. Here's a sign that is quite characteristic of Fabry disease. So you'll see these pale areas at the back of the thalamus. I'm referring to these areas here on this scale. These areas bilaterally, and they're seen at the back there. That's the so-called pulvinar sign. Oh, thank you. That's the pulvinar sign, and it's an indication of structural alteration in Fabry disease, which was originally thought to be pathognomic, but I'm told it does occur in other types of metabolic and non-metabolic conditions affecting the brain. Another challenge for us is the importance of an early diagnosis. Now, we've talked about this already. Without a diagnosis, we can't really be entertaining the importance of treatment, and we can't be talking of preventing disease progression. And it's prevention of disease progression that's very much the focus of treatment. Here are some of the essential issues around raising a diagnosis. I want to just emphasize something that we've said before, that the demonstration of a mutation in DNA is an insufficient basis for diagnosing Fabry disease. But on the other hand, we must emphasize that in females, genetic analysis is crucial, because simply measuring the level of the enzyme will often be uninformative in females. Another issue is this issue of the awareness of Fabry disease. And I think I just want to highlight something that Gabor mentioned, which is the importance of the internet. I think perhaps this is something we can exploit more and more. We're reaching out to patient communities, but if we think that we're actually making an impact, I suspect that we're making a very small impact. I only last week met a patient who diagnosed himself on the internet. He noticed these abnormal skin lesions. He typed it into Google. He typed in the nature of his skin rashes and the fact that he had difficulty sweating. And he went to a GP who felt that the skin rash, well, the patient said it was angiokeratoma. And the GP had never heard of angiokeratoma. The GP did refer him to a dermatologist, and the dermatologist confirmed that this probably was angiokeratoma. The dermatologist had heard of Fabry disease, didn't think the patient had Fabry, but did undertake to diagnose with an enzyme assay. And the diagnosis was made. So here was I know this has been previously reported, but I was very struck by such scrutiny that leads people to really look to see what the evidence is, because you'll be aware that there is a lot of data on the prevalence of these white matter lesions, and there have been studies that have looked at MRI appearances and recorded MRI appearances, but the impact of enzyme therapy on these appearances was not the primary objective of the study. So I think you do raise an important point about scientists and clinicians being very rigorous in terms of the publications that they're responsible for. So I'm aware that there's a debate on whether ERT has an impact. And I'm not necessarily saying it doesn't have an impact, but I'm giving an illustration of a patient where it didn't have an impact, and really raising this as a challenge. The whole issue of the central nervous system effects of Fabry disease is very much a challenge for us for the future.
I understand the paper wasn't directly relevant to white matter lesions, but just that there may be some benefit.
There may be some benefit. Yeah. And there may be some benefit in terms of alterations in cerebral blood flow. You may know that the studies in fact indicate that patients with Fabry disease at baseline appear to have an increase in cerebral blood flow. So there's a dysregulation of cerebral blood flow, and enzyme replacement therapy has been reported to reduce cerebral blood flow. In other words, to restore a degree of normality to the controlling mechanisms. But quite how that occurs or why that occurs is improperly understood. At one point it's encouraging that there are these documented vascular abnormalities, but you'll see, that's an area where there's abnormal perfusion, but here's a patient with Fabry disease with really severe changes in the basilar circulation. You'll know that often the parts of the brain where strokes occur in Fabry disease tends to be at the posterior circulation relatively more than the anterior circulation. And patients with Fabry disease have vascular abnormalities. Some of these vascular abnormalities lead to disturbances of blood flow. Some of these vascular abnormalities are due to structural changes in the blood vessels. And Uma, amongst others, has shown us that you can visualize some of these structural changes by close examination of the retina. That also can show these changes. But the precise pathophysiology underlying these structural changes is again something that's not well understood, and it's another challenge for us to try and unravel why that happens. Here's a sign that is quite characteristic of Fabry disease. So you'll see these pale areas at the back of the thalamus. I'm referring to these areas here on this scan, these areas bilaterally, and they're seen at the back there. That's the so-called pulvinar sign. Oh, thank you. That's the pulvinar sign, and it's an indication of structural alteration in Fabry disease, which was originally thought to be pathognomic, but I'm told it does occur in other types of metabolic and non-metabolic conditions affecting the brain. Another challenge for us is the importance of an early diagnosis. Now, we've talked about this already. Without a diagnosis, we can't really be entertaining the importance of treatment, and we can't be talking of preventing disease progression. And it's prevention of disease progression that's very much the focus of treatment. Here are some of the essential issues around raising a diagnosis. I want to just emphasize something that we've said before, that the demonstration of a mutation in DNA is an insufficient basis for diagnosing Fabry disease. But on the other hand, we must emphasize that in females, genetic analysis is crucial, because simply measuring the level of the enzyme will often be uninformative in females. Another issue is this issue of the awareness of Fabry disease. And I think I just want to highlight something that Gabor mentioned, which is the importance of the internet. I think perhaps this is something we can exploit more and more. We're reaching out to patient communities, but if we think that we're actually making an impact, I suspect that we're making a very small impact. I only last week met a patient who diagnosed himself on the internet. He'd noticed these abnormal skin lesions. He typed it into Google. He typed in the nature of his skin rashes and the fact that he had difficulty sweating. And he went to a GP who felt that the skin rash, the patient said it was angiokeratoma. And the GP had never heard of angiokeratoma. But the GP did refer him to a dermatologist, and the dermatologist confirmed that this probably was angiokeratoma. The dermatologist had heard of Fabry disease, didn't think the patient had Fabry, but did undertake to diagnose with an enzyme assay, and the diagnosis was made. So here was I know this has been previously reported, but I was very struck by a patient sitting in front of me who diagnosed himself on the internet, And I suspect that more and more we're going to be seeing people feeding their symptoms into a search engine. And these are obviously very, very powerful tools.
But do you know what website he got it? There are numerous websites on fabry.
Right.
I'm curious, what was the...
I can ask him, actually, because this may be something we ought to be linking these websites to together, and maybe linking them into a fabry patient information website. The internet is a very powerful tool, and I think that we need to harness it more. Yes.
So the impact is not known, but on April 2nd, as part of Fabry Disease Awareness Month, I made a Facebook post, and in 3 days, it was viewed by over 20,000 people.
Right.
And by now, it's been viewed by 26,600. So from where we started, and so the impact is not known, but our reach, not only in our community but all around the world through the internet sites, is really getting much better. So we followed that with how would you know if you had fabry, which reached 10,000 people, and another. So there are a few similar posts, but I was very, very surprised. We know we have 1,060 Facebook friends on our Facebook page, but I was absolutely amazed that we reached almost now 27,000 people with that one post.
Wow.
It's just amazing.
Yeah. Here's another challenge. How do we understand and develop new biomarkers? This is an illustration of lyso-Gb3, which Gabor has mentioned. It's the biomarker about which there's greatest interest, but there may be others. And I'm frequently struck as I see patients and as we teach in our institution that when we're treating patients with hematologic illness, but also very much so when we're treating patients with Gaucher disease, our treatments are guided by a range of laboratory variables and a range of easily detectable clinical signs which alter with treatment. Of course, in Fabry disease, one does have physical signs, for example, the rash, but again, one is struck that treatment very rarely actually leads to a clear improvement in a physical sign or a clear improvement in a biomarker. This is a real challenge. It's a challenge we've had for 10 years. I'm interested, Gabor, obviously, that you're able to measure lyso-Gb3 almost immediately upon your initial evaluation of the patient. It's not a facility that all of us have. Most of us are depending on stored samples for measuring some of the really important laboratory variables that we might want to know about, like antibody titers to ERT, like lyso-Gb3 levels. And here is an important area for future collaboration. We've seen the enzyme before. The infusion of the enzyme, it clearly has an important impact on the metabolic defect. I think all of us would agree that it slows disease progression. In selected patients, we know that it could even reverse disease progression, but I'll emphasize with some slides later on that it's very important to treat patients early. There are 2 licensed enzyme preparations available. Here we're itemizing the evidence a little bit more. In terms of renal function, I think most of us would agree that enzyme therapy has very much got a demonstrable benefit for the majority of patients. Again, recognizing that patients with established renal failure, established kidney fibrosis, they won't respond. Established proteinuria rarely responds. The effectiveness of the treatment for pain. Now, here is something where patients tell us that enzyme therapy is effective. It's effective in the treatment of gastrointestinal dysfunction. The impact of the enzyme on the heart. Again, I want to explore this a little bit more, and I'm sure Tarek will be exploring it more. Yes, there's good data that aspects of cardiac function will improve. I was interested in Peter's comments on the ejection fraction and some of the measures that we've been reliant on 5 years ago. I'm also aware of a growing recognition that the figures that we choose to assess response upon, there's some debate about which are the most important figures. So we need to be skeptical, but we need to recognize that, yes, it does seem to have an impact on cardiac function. When should we start enzyme replacement therapy? The guidelines I've chosen there are early guidelines, but I think that that's still a basis on which to start any discussion about when the guideline should indicate when to start treatment. It does say that males are more severely affected and they're more affected at an earlier age than females. It does emphasize that for children, one generally speaking should be waiting for the development of symptoms. Treating asymptomatic children asymptomatic boys is controversial. There's perhaps a need to standardize these guidelines across different communities, across different countries. There are 2 enzyme preparations available, and the basics of the 2 are itemized there on the slide. There haven't been direct comparisons between the 2 products. Head-to-head studies haven't been contemplated or completed. That's not strictly true. A couple of head-to-head comparisons have been made, but there's general recognition that those have been very small studies. It's becoming clear that the event rate in Fabry disease is low. Patients have progressive disease, but when we're measuring clinical outcomes, the number of events that occur is actually quite slow. It was very clearly demonstrated in the Fabrazyme phase 4 study that the event rate is quite slow. It's also very clear from the Canadian Fabry Disease Initiative. We may be hearing a little more of their latest data, but they also demonstrate that the events that occur in Fabry patients, they occur at a relatively slow rate. And so measuring the impact of interventions on clinical outcomes is necessarily going to be a slow process, and it'll take many years for us to demonstrate whether a different dose of the 2 products is important, whether the products are equivalent or not. I would stand by the statement that after the shortage, patients who've switched from one to the other, they do not overall seem to have suffered deleterious effects. I'd also say that the 2 products at their licensed doses, generally speaking, the data are that they're equivalent. I'd also say that there's increasing need to investigate the impact of using lower doses of Fabrazyme, and that's certainly an initiative that we're very keen to do more work on in the United Kingdom. I've been impressed that so many of the patients who've switched from agalsidase beta to agalsidase alpha, yes, they've been stable, but so many of the patients who've switched to lower doses of agalsidase beta, they too have been stable. And as we've seen the introduction of newer enzymes in Gaucher disease, I'm constantly reminded that in Gaucher disease, we don't use simple one dose for all patients. We try to titrate the dose according to the individual needs of the patient. And I think that after 10 years, we're now confident enough to talk with our patients and to reach a compromise on dose after discussion with patients and their families.
I have a question about that.
Yeah.
So if a physician chooses to administer a different can you use something other than 0.2 for Repligal or 2 milligram or 1 milligram per kilogram for fabry?
I think, yeah, I think you raise a really important point there. The physician prescribes a dose, recommends a dose. It's the patient who takes it, and it's prudent that every physician should recognise that any discussion about doses needs to be one that's open and that needs to be had with the patient. It's a discussion rather than a prescription.
I guess my question really is, are you in any legal or ethical, do you have any problem legally or ethically in administering a dose that's not according to the label?
No, but in the sense that if something happens to our patients and we did a non-approved dose and we did not discuss it with the patient with all the pros and cons, then you will have to explain to somebody why you did otherwise. But we can basically give 10 times the dose if we feel it's appropriate, or give 10 times lower the dose if we feel that that's appropriate. But it has to be, like Atul says, a joint
So as long
decision.
as long as it's a discussion with the patient, you're okay in the medical world.
Yeah, yeah.
I guess the only other problem that I see with that, I think it's a great thing for you to be able to administer at the dose that you think is appropriate. I think the other issue might be when it comes to insurance. So for instance, if you said, I want to prescribe Repligal at 0.5 mg per kg of body weight, would insurance push back on you to say you're administering more than double the prescribed dose and we're not going to pay for that?
Exactly.
They would. I think they would. And I think...
patient says no.
Well, I'm not going, and maybe I should answer, but we're not going to enforce our ideas. It's you give an advice, you talk with the patient, you explain why you give that advice, and I've not had many problems.
Sure.
Yes.
In my country, I agree with you. The decision to increase or decrease the dosage is on medical ground, and there is no problem. But in our country, if you don't do what is written in the label, it is called off-label, and there is a different administrative process in the term that it is the hospital itself paying the treatment, and the regional health service is not paying. So this could be something not really favored by the hospital administration, because it charges the hospital of the payment of
Yeah, usually the surplus of what you give more, but if you give less, then usually nobody complains.
It's off-label too.
But it's equally important. I think the issues that have been raised by Jerry are excellent, and I have to say I disagree a little bit with your answers, because we never dare increase it. We would basically, in France, be outlaws, because you're charging the national health system twice or 3 times more. If allowed, I would immediately go for increasing the dose or whatever, Repligal or Fabricide. In contrast, decreasing, you're using an off-label dose, and all the results, which are already so difficult to be demonstrated, I mean, in terms of outcome, have been with the currently approved dose. So you have no idea what would be the outcome if you would use, for instance, 0.1 of Repligal, maybe absolutely massive.
Yeah, but I think what you've done successfully and importantly is raise awareness of some of the elephants that are in the room. With regard to Replagal, the issue very much is whether a higher dose might be more effective than the currently licensed dose. That's very much the issue that we're skirting around. The problem with using higher doses is that that would be financially prohibitive. We're able to prescribe the licensed dose. If you want more than the licensed dose, you would have to go to the company who would have to pretty much provide it free of charge. People have done trials using higher doses of Replagal, and we've got one that's just been accepted for publication this week. Generally speaking, it's been difficult to demonstrate that double the dose of Replagal has more effect than the licensed dose of Replagal. That's been the general finding in the study. I'm aware that there's a single publication from Schiffman on a small number of patients that using double the dose of Replagal seemed to slow the decline in renal function. Yes, there is that clinical observation. But when you take the totality of studies using double dose Replagal, it doesn't seem to make a lot of difference. What about using a lower dose of Replagal? That was a point that Dominic raised yesterday. I don't think it will be acceptable to physicians or patients to be using lower doses of Replagal. That's the bottom line there. So that's the point that Jerry's raising, that when you decide on a dose, it's not something that the doctor decides on, it's something you've got to discuss with patients, and it's got to be acceptable. The issue with Replagal is that it's actually very well tolerated. It's very well tolerated at its licensed dose. It's available at its licensed dose. It's funded at its licensed dose. Why would you use a lower dose? Uma.
So, I think the one thing we haven't discussed is, there are other precedents where for example, with Gaucher's, of course it's a very different condition, macrophages. We know that you can tailor dose, but we do have good biomarkers.
Yes.
So the issue we've got here is that it's a heterogeneous disease, and also we don't have biomarkers. So trying to individualize treatments, I think actually is going to be really, really difficult.
Yes.
In fabry, and I think that's the problem we face.
Yes.
And that's why I agree with what Dominic is saying, because we don't really have that tool to be confident.
Yes.
To reduce our increasing.
Yes. So I think we need more rigorous studies of Fabrazyme at different doses, comparing it to different products, storing samples if necessary to do biomarker analyses, but also very much bringing us into the real world, because there's a real world here which is around the cost of these treatments, and which is around the fact that if you can reduce the cost of these treatments, then that's going to have a significant impact on allowing us to access newer enzyme formulations for currently untreatable patients, on allowing us to access ancillary therapies, for example chaperones, which may improve the effectiveness of enzyme replacement. And I think this is very much the real world, because there are two important papers. One I think is published this week. The other one has very recently been published. And these are telling us that certainly if you look at very hard clinical outcomes of enzyme replacement therapy given over prolonged periods of time, particularly to patients with significant cardiac problems, there are severe limitations of enzyme therapy given on its own. And again, I was struck by Peter's comment that the arrhythmias that are a problem for Fabry patients, we need to understand these, and we need to be very much better at preventing them. This is the typical appearance that Frank Biedermann explains to us is a challenge and is poorly responsive to enzyme therapy. And this is the paper from this is the slide from Dominic's paper telling us that patients with established proteinuria may not benefit that greatly. So when it comes to enzyme therapy, I want to just emphasize the importance of supportive therapies in all of these different areas of the disease, which help to optimize clinical outcomes for patients. But I want to spend a couple of minutes, if I may, just talking about the new treatments. We're currently very excited about gene therapy in London, but not for Fabry disease, but for haemophilia B. We have an individual working with us who's demonstrated the effectiveness of gene therapy in a single gene disorder, and we're excited that he's joined us at our new institute at University College London. We're hoping to extend some of those studies into other single gene defects. I think in terms of the panorama of what's going to be available for Fabry patients in the short and medium term, it's the chaperones. And as you know, there are 2 phase 3 registration studies underway. And interestingly, there's this other study also, this co-administration study of the chaperone with enzyme. Just to briefly talk about these studies, these are the 6-month results of migalastat, and demonstrating the difference in response between placebo in red there and migalastat treated patients in blue. You can see that there are differences in response. This is measuring the reduction in in capillary, kidney interstitial capillary GL3. So these are patients who had renal biopsies. And there's every hope that at 12 months we'll be seeing more impressive results than we are at 6 months. I think chaperones offer a promise, but these are available only to patients with responsive mutations, and hitherto the response has been very limited. I'm personally quite interested in these studies. What about combining the chaperone with enzyme replacement therapy? Certainly this is likely to have significant advantages because it could be used in patients who don't have amenable mutations. And there is some preliminary data that combining the chaperone with enzyme does seem to increase enzyme activity in plasma, and does also seem to increase enzyme activity in tissues, and this is irrespective of whether the chaperone is combined with Replagal or Fabrazyme. And I think that it's going to be the results of these studies that will help us to improve enzyme replacement therapy for our patients. But the results of these studies will, of course, in turn, raise other challenges. How are we going to be able to afford co-administration of chaperones with enzymes? So here I've tried to list some of the aspects of the condition where I think we're going to be really focusing on and looking for answers in the next coming years. I'm going to stop there, and thank you for your attention.